Hi, good morning. My name is Dr. Jason Wasfi. I'm an associate professor at Harvard Medical School. I'm a cardiologist and I direct our program in outcomes research at the Massachusetts General Hospital Heart Center. I am also the chair of New England CEPAC. We are so grateful to all of you who are here today to discuss a critically important emerging therapy, tabelecleucel, which I will call Tabcel, given the length of the name, for Epstein-Barr virus positive post-transplant lymphoproliferative disease. I'd like to start by introducing my colleagues on the New England CEPAC. And so at the beginning of every meeting at this moment, we make sure that all speakers disclose any financial relationships with industry. For the New England CEPAC, every member of our panel who is present has met the ICER conflict of interest policy. So when I go through and defer to people to introduce themselves, they will say briefly about their work and tell us at that time if they have any updates to their previous declaration. And I am going to go through, just for the sake of not missing anyone, I'm going to make sure to go through by alphabetical order. And I'd like to start with Dr. Austin Fracht.
Good morning, Austin Fracht. I am with the Department of Veterans Affairs. I'm a health economist there. And I also have an appointment at the Harvard T.H. Chan School of Public Health. And I have no other conflicts of interest to disclose.
Thank you, Austin. Dr. George Goshua.
Good morning. It's a pleasure to be here today. I am a hematologist oncologist at the Yale School of Medicine and a principal investigator of a quantitative decision science lab focused in hematology oncology. I have no COIs to disclose.
Thank you, George. Rebecca Kirsch.
Good morning, Rebecca Kirch, based in Washington, D.C., with the National Patient Advocate Foundation. No changes to my disclosures.
Thank you, Rebecca. Dr. Steve Kogan.
Morning, everybody. I have no updates to my conflicts of interest. My name is Steve Kogat. I am professor and vice chair of the Department of Pharmacy Practice and Clinical Research at the University of Rhode Island College of Pharmacy.
Thank you, Steve. Don Kreese.
Good morning, everybody. I too have no updates to my conflicts disclosure, which I have none. I am an attorney. I serve as New Hampshire's utility ratepayer advocate, but I'm affiliated with the CEPAC in my capacity as a person who raised an awesome daughter to adulthood, despite the fact, or maybe because of the fact, that she lives with cystic fibrosis.
Thank you so much, Don. Dr. Julie Coopers.
Good morning, everyone. I'm Julie Coopers. I have no updates to my conflicts of interest. I am the VP of Clinical Consulting at Alera Group. I'm also a family nurse practitioner and health researcher, and I consult with employers on key issues that are impacting their health plans.
Thank you, Julie. Dr. Aaron Mitchell.
Hello, I'm an assistant attending of medical oncology at Memorial Sloan Kettering. And I have no.
Thank you, Aaron. Dr. Brian O'Sullivan.
Hi, I'm Brian O'Sullivan. I'm a professor of pediatrics at Geisel School of Medicine at Dartmouth, pediatric pulmonologist and director of the New Hampshire Cystic Fibrosis Center, and former chair of the Institutional Review Board at UMass Medical School.
Thank you so much, Brian. Joe Porter.
Good morning, everybody. This is Joe Porter. I'm the Chief Strategy Officer for the New Hampshire Center for Justice and Equity, and formerly the Director of the Institute for Health Policy and Practice at the University of New Hampshire, and no additions to my conflicts of interest, of which I had none.
Thank you, Joe. Dr. Joe Ross.
Thanks, Jason. Hi, my name is Joe Ross. I'm a general internist and professor of medicine and public health at Yale, and I have no updates to my disclosure.
Dr. Jason Schwartz.
Hi, good morning, everyone. I'm Jason Schwartz. I'm an associate professor in the Department of Health Policy and Management at the Yale School of Public Health, and I have no conflicts.
Thank you, Jason. Dr. Rishi Wadera.
Good morning, everyone. I'm an associate professor at Harvard Medical School and the Harvard School of Public Health and a cardiologist at Beth Israel Deaconess Medical Center, and I have no updates to my disclosures.
Thank you, Rishi. Anyone I missed? I don't think so. Thank you all for joining us. So next, we're going to move to our experts. We have an amazing group of patient experts and clinical experts that have joined us today. So we're going to ask them to introduce themselves and tell us maybe briefly about them and declare any potential conflicts of interest. And I'll start with our clinical experts, starting with Dr. Upton Allen.
Upton Allen, I'm head of the Division of Infectious Diseases at the Hospital of Sick Children, Sick Kids at the University of Toronto, and I'm interim director of the Transplant and Regenerative Medicine Center at Sick Kids. I focus a lot on EBV related PTLD, post-transplant lymphoproliferative disorders, and have previously co-authored guidelines on the diagnosis and management of these disorders. I have no updates to the conflict of interest disclosure.
Thank you so much, and we're so glad to have you. Dr. Sarah Nickfro.
Yes, hi, I'm Sarah Nikipro. I'm at Dana-Farber Cancer Center here in Boston, part of Harvard Medical School. My disclosures have not changed, but I've actually been working on EBV T-cell immunity for over 25 years and had the pleasure of serving as a principal investigator on the tab-cell trials conducted within the DFCI space.
Thank you, and we're so grateful for your lending expertise today. We also have two amazing patient experts. And I'll start with Joseph Kopek.
Good morning. My name is Joe Kopek, and I live in Sturgeon Bay, Wisconsin, which is northeastern Wisconsin and the home of the Green Bay Packers. And basically, I'm the patient who was diagnosed with this disease about 10 years ago, and I'm in remission and received the traditional treatment at the Mayo Clinic through the hematology department. So I'm still here.
Thank you. We're delighted you're still here, and I'm so glad to hear that you're doing well. Best wishes to the Green Bay Packers on Sunday. We will move on next to Doug Worthen.
Hi, good to be with everybody. No conflicts to disclose. And in 2007, diagnosed with stage 4 peripheral T-cell lymphoma. In 2008, basically got EBV positive PTLD under the care of Dr. Richard O'Reilly at Memorial Sloan Kettering. Had a really positive experience with life-saving experience with tab-cell, and still here today as well. Grateful to all you doctors out there. So thank you.
We're happy for you. We're grateful for you lending your expertise, and just so happy to hear that things have been going well for you. Thank you again for joining. So with that, there will be other speakers that you'll see during this session, including policy roundtable participants and any individuals making public comments. The kind of rules are the same as for the people you've heard from already. They should announce any financial relationships with industry or any other potential influences on judgment when speaking. And the ICER staff will present this information publicly on slides. So with that, I'd like to cede and introduce the president and CEO of ICER, Sarah Emont.
Dr. Wasfi, thank you. And also my gratitude to everyone who is participating in the meeting today. As Dr. Wasfi said, we're going to use tab-cell for reference of the drug today for ease. We also would ask the indulgence of the audience that instead of Epstein-Barr virus positive post-transplant lymphoproliferative disease, we will use PTLD for short today for efficiency's sake. So thank you for indulging us with that, just for ease of conversation. It's my pleasure to be joined with my esteemed colleagues from ICER listed on this slide. You'll be hearing from some of them shortly and throughout the meeting today. They are the experts that provided the report that you should be using to sort of follow along today, as well as we'll hear from ICER's founder and special advisor, Steve Pearson, when he moderates the policy roundtable this afternoon. Next slide, please. So why are we here today? we really take a moment at the beginning of every ICER meeting to remember what we've heard from patients. And we have heard from patients throughout this review, as we do with all reviews, that this experience really stuck with us and we wanted to share it with you today. It was a really complicated and frustrating time. I was wanting to be healthy again from all of the different treatments and everything after transplant. And so they first thought I had gut graft versus host disease, and they were giving me immunosuppressants. And because of the immunosuppressants, I think that's when the EBV positive PTLD went nuts through my GI tract. I went back into the hospital and I was 120 pounds. My dad, he pretty much took time off from work to become an expert in this, to be my main patient advocate. My mom moved closer to where I was receiving treatment so I could have a place to stay when I was receiving treatment outpatient. It was really hard on the family. How do you say no to what you think is the best care? It's like you just kind of have to make it work. These themes will come up today in our conversation about the burdens that are placed on patients to receive care for a rare condition such as PTLD and what kind of options and hope might be coming with a new treatment. Next slide. But what are we doing here today? What happens the day that these treatments are FDA approved? There may be celebration for a treatment for something that hasn't had adequate treatment before or in a different condition. Maybe it's an advancement over the previous treatments. But the questions don't end when we have FDA approval. We need to talk about the risks and the benefits. How do these treatments fit compared to what we already do now? What are the costs and the reasonable prices that should be charged to society for a new therapy? And what do we know from these consequential conversations about comparative effectiveness that should inform evidence-based policymaking in the future? That's what we're tackling today here with this New England CEPAC meeting. Next slide. And we do this because we are unabashedly talking about population health while also talking about the care of patients who have PTLD, because we know the impact that has had broadly on our society when we spend more and more for our healthcare, but oftentimes get less and less health for that spend. So we remember these families. We remember the families like the wards of Chicago who went $80,000 in debt when their twins were born premature. We remember Sherry Foy, who was forced into bankruptcy because she had to have surgery to remove her colon. And we remember the Bucks of Arizona, who when they tried to see their doctor were turned away because they had outstanding bills with that doctor and then ended up in the emergency room and got more expensive care for something that could have been treated at the doctor's office. And more recently, officials in Delaware delineated exactly what was behind the fact that they had to raise healthcare premiums for state employees 27%. And they said it was because of outpatient medical procedures, specialty drugs, and emergency room visits. So on the next slide, when we think about the evidence that we are going to talk about today for this new treatment and what a fair price is for that treatment, we remember all of the other people in the healthcare system who are impacted by consequential decisions about price and access. And we can do so while still staying focused on the patient who's in the room with the doctor with this condition needing to address a life-limiting condition such as PTLD. Next slide. So you are here because you are watching the New England CEPAC in action. They are the independent appraisal committee that has introduced themselves this morning, convened by ICER, the Institute for Clinical and Economic Review, an independent nonprofit research organization. We are committed to having these conversations in public. We are also committed to bringing our research to these experts at the New England CEPAC for vote and deliberation, which will make up a significant part of our conversation today. Next slide. We, as Jason has been wonderfully reminding everyone, very transparent about our funding. I have no additional conflicts except I am an employee of ICER, so that is my disclosure. ICER is very careful about how it takes its funding. All of our research is supported by nonprofit foundations. Any money we take from someone who has an interest in the healthcare system, like a life sciences company, a health plan, a PBM, or a provider group, only supports the work that we do to run an annual policy summit for our policy leadership forum. And you can find a list of all of our funders on our website. Next slide. So a little bit about following along at home for that evidence report you might have in front of you as we go through the different sections today. And how was that produced? It takes about 8.5 months to develop an ICER report, and we have moments for engagement and public comment throughout in order to get the best possible report of the state of the evidence for this new treatment for PTLD. In our scoping phase, we talk to patients and clinical experts, the manufacturer, and other key stakeholders. We had the evidence synthesis piece led by Dr. Grace Lynn, who you'll be hearing from in just a moment. We bring the report out for public comment, but then also review by experts listed here, both from the patient and the clinical expert community. That draft report is then revised based on the public comment that we hear. That evidence report was posted about 2 weeks ago, and it is the subject of the deliberation today. Next slide. So we'll talk about value a lot today, and so it's good to have a visual of what we're talking about when we are talking about value assessment. We are talking about both the things that are relatively easy to quantify, which you see here in the green boxes. How much better do patients feel? If it's a life-limiting condition, how much longer do they live? What kind of quality of life comes with that treatment effect? Do they have fewer side effects? Are they able to get back to their activities of daily living? And then we have a conversation about the costs associated with that health gain. How much are we spending? How much are we saving overall? But we acknowledge that those are only some of the dimensions of value that might matter to patients as they think about a new therapy, and for policymakers as they're thinking about access. But there are a lot of parts of value that are important to think about from a deliberative perspective, and that's represented here in the blue bar. And that's what our CEPAC will be doing today. They'll be talking about special ethical priorities, benefits beyond health that might come with this treatment. It is an important context for thinking about value, that there are things that we quantify as thinking about being a fair part of thinking about the price that a manufacturer should charge society for a therapy, and then parts of the value that come from a new therapy that actually are shared with society and don't get quantified to accrue back in price. You'll hear that through some of our deliberation today. Next slide. All right, you've almost made it through the convening and opening remarks. Congratulations. Next, we'll be hearing from Dr. Grace Lynn, and she'll be talking about the clinical evidence. After that, Dr. Ujung Lee will be talking to us about the economic model that was developed to answer the questions about long-term value for this therapy, and then we'll hear from the public. After a lunch break, you'll hear the New England CEPAC deliberate on that evidence. There are key questions that they will be asking. Those questions are also available on our website, our voting questions, if you want to take a sneak peek at what we'll be talking about then. And then after a break, the policy roundtable will convene. Dr. Steve Pearson will talk with the patient and clinical experts, as well as experts from the payer community, about what does it mean to have this new therapy, to have what we know about the evidence and its value as deliberated today in terms of making evidence-based policy decisions in service to both individual health and population health. We should be wrapping things up today around 4 o'clock Eastern. With that, it is my distinct pleasure to introduce the Medical Director for Health Technology Assessment here at ICER, as well as the Professor of Medicine and Health Policy at UCSF, Dr. Grace Lynn. Thank you, Grace.
Thank you, Sarah. Thank you for the introduction. Good morning, everyone. As Sarah said, I will be presenting the clinical evidence for tab-cel for EBV positive PTLD. Next slide, please. I obviously did not put this presentation or report together alone. Together with my colleagues Avery McKenna and Finn Raymond at ICER, we are going to summarize the evidence for tab-cel for you. Our disclosures are listed. ICER does provide financial support to me and the University of California, San Francisco for the work I do on this report. Next slide, please. So PTLD is EBV positive PTLD is a rare, serious, and often fatal complication of either solid organ transplant or hematopoietic stem cell transplant. And you'll see there's going to be a lot of, I apologize, there's a lot of abbreviations in this presentation today because of the lengthy terms that are used. The majority of PTLD is associated with the acquisition or reactivation of Epstein-Barr virus, and hence the moniker EBV positive PTLD. The incidence of this disease varies based on transplant type. For solid organ transplant, it also depends on the type of transplant you are getting, with transplants that require more immunosuppression, for example, like a lung transplant or a multi-organ transplant, require higher levels of immunosuppression, have a higher incidence of PTLD than kidney transplant, which relatively speaking has lower levels of immunosuppression. So the incidence goes from less than 1% to 30% for solid organ transplant. For the stem cell transplant, the overall incidence is approximately 3%. Risk factors for developing EBV positive PTLD. One is that if you are EBV negative as a recipient, so you have not been exposed to EBV prior to the transplant, you're at higher risk. Transplants, as I said, transplants requiring a higher level of immunosuppression, age, and this is mainly children, young children, because they haven't been exposed to EBV, and then older people because they have their immune systems are relatively less robust. And then a history of severe graft versus host disease in people who've had a stem cell transplant that also puts you at higher risk for developing EBV positive PTLD. Next slide, please. So people with EBV positive PTLD may present with or without symptoms. So in some cases, we are now monitoring EBV levels post-transplant in a patient. So as that viral level increases, the transplant team may act to try to treat that prior to people actually developing symptoms. In some cases, either if there's no monitoring, EBV positive PTLD becomes symptomatic. So people will have generalized symptoms similar to lymphoma, so fatigue, swollen glands, night sweats, unintended weight loss. If the EBV positive PTLD is affecting a specific organ system, you might get symptoms specific to that organ system. And most commonly that occurs when the disease is in the gastrointestinal tract or the lungs or the central nervous system. And the majority of cases are what we call a monomorphic diffuse B-cell lymphoma subtype. And this is mainly important when we get to the treatment, that a lot of the standard treatment is one that is similar to the monomorphic diffuse B-cell lymphoma treatment. Next slide, please. So in terms of treatment, here are a list of the treatment options. So initially, when disease is detected, the first step is reduction of immunosuppression. So one of the things that happens when you suppress the immune system is that the T cells aren't able to attack the EBV infected cells and keep them under control. And so the thought is if you reduce the immunosuppressant and allow the native immune system to reconstitute, that you might be able to control the disease in that manner. If you have a tumor, for example, in a specific place, sometimes you can also do surgery or radiation if you have limited disease. If reduction of immunosuppression and or the local treatment is not successful, then people are offered the standard therapy of rituximab with or without chemotherapy. The rituximab treatment is in both the solid organ transplant and the stem cell transplant. Chemotherapy is mainly used in the solid organ transplant cases because the patients who have stem cell transplant, you actually want to avoid chemotherapy if possible in those patients. So approximately 50% of people will respond to this therapy of rituximab with or without chemotherapy. Unfortunately, 50% either will not respond or will relapse after treatment. And we call this the relapse refractory population, which is the population of interest for tab cell treatment. So in the relapse refractory population, there is no standard treatment. So once you get to that stage, people you either try to find clinical trial or there may be other chemotherapies that get tried, but there's no standard treatment at that point. In people who are not treated or who are in relapse refractory and don't get treatment, EBV positive PTLD can be rapidly fatal, with death coming in weeks to months. If you respond to the first-line therapy, the survival estimates are 40 to 60% survival at 5 years. Next slide, please. So today we're going to talk about Tab-cel. It is a drug that has been treatment that's been already approved in the European Union under the name Ebvallo. It was approved in 2022 for patients with relapsed or refractory EBV positive PTLD who had received at least one prior therapy. The manufacturer filed a biologics license application with the US FDA back in May, and again, for the same population. So what is Tab-cel? Tab-cel is what we call an off-the-shelf allogeneic T-cell immunotherapy. And what we mean by off-the-shelf means that there is a bank of T-cells that is kept, or that are from healthy donors who are donating EBV positive donors that are donating these T-cells. And so this bank of T-cells is kept at the manufacturer. And when a patient is diagnosed with PTLD and is eligible for this treatment, the treating physician can request matching with the HLA, human leukocyte antigens, to see if there's a match for that recipient, to see if we can then have those cells transferred into the recipient. So the EBV positive T cells then target and eliminate EBV infected cells, therefore treating the PTLD. So this treatment is administered intravenously for 3 doses per 35-day cycle for a minimum of 2 cycles. Now, the treatment can be administered either as an inpatient or as an outpatient, wherever the patient, if the patient is healthy enough to be as an outpatient, it can be treated in the outpatient setting, or if the patient is ill and in the hospital, it can also be treated in the hospital. Next slide, please. We were fortunate enough to talk with patients who were diagnosed with EBV positive PTLD, and you'll hear from a couple of patients we spoke with during the review later on today. And what they told us was that PTLD has a tremendous impact on physical, social, and emotional functioning of patients and caregivers. Remember that patients, this is a post-transplant disease, so patients have already been ill and gone through a rigorous transplant process, and they may be thinking, wow, I got a transplant, I'm expecting to regain health, only to become ill again. And this places an additional burden on caregivers. For patients with relapsed or refractory disease, there are very limited treatment options. And the treatment options that are out there are often chemotherapy, which can be very toxic. We also heard that insurance barriers may be an issue. Since it's a rare disease, patients may need to seek treatment out of network. And they are also concerned about the potential high cost of new treatments. Next slide, please. So we'll talk about the scope of the review. This is, again, people with relapsed or refractory EBV positive PTLD who have received at least one prior therapy, and that one prior therapy being rituximab with or without chemotherapy. We'll talk about the interventionist Tab-cel, and we'll compare this to usual care, which may include pharmacologic or non-pharmacologic treatment options. And our key outcomes are overall survival, objective response rate, and then safety and adverse events. Next slide, please. So let's dive into the clinical evidence. So our evidence base comes from mainly one phase 3 single-arm open-label study of Tab-cel called the ALLELE study. And again, this is the solid organ or stem cell transplant recipients with relapsed or refractory EBV positive PTLD. We also have expanded access programs both in the United States and in the European Union with a similar population, basically people with no therapeutic alternatives or not eligible for clinical trial enrollment. Our usual care arm, the data we drew from our retrospective cohort studies of solid organ transplant recipients with relapsed refractory disease, or stem cell transplant recipients with relapsed or refractory EBV positive PTLD. And then there was also an analysis of a subset of the allele trial participants compared with a retrospective chart review. Next slide, please. So let's talk about the allele trial in more detail. Again, this is a phase 3 trial, multi-center, single-arm trial. The treatment group got tab-cel administered IV for 3 doses per 35-day cycle for a minimum of 2 cycles. And the median number of cycles in the trials, in the stem cell therapy group, they got a median of 3 cycles. In the solid organ transplant group, there was a median of 2 cycles given. There were 43 participants total. 1/3 had stem cell transplant and 2/3 solid organ transplant at a median age of 49. A little less than half were female, primarily white, and about 2/3 had the diffuse large B-cell lymphoma disease morphology. Next slide, please. So before I talk about the results, I want to just briefly go through the response classifications because this becomes important in terms of understanding what we mean by responder versus non-responder. So in the responder group, we have people who had a complete response. And what this means is if they had tumors, those tumors shrunk to less than 1.5 centimeters. So anybody who had tumors and that they shrunk to less than 1.5 centimeters, they were considered a complete response. If only 50%, if the tumor shrunk only by 50% or more, then, but they didn't shrink to below 1.5 centimeters, then they were considered partial responders. And this made up the responder group. If they didn't have any shrinkage or growth of the, or they had growth of masses despite treatment, that was termed stable disease, and they were considered a non-responder. And then if they had growth of the masses, that was considered progressive disease. And again, they're considered non-responders. There were a few people that were not able to be evaluated, and that was due to death, withdrawal, or the fact that they were newly enrolled and didn't have enough follow-up data. Next slide, please. So let's talk about the response results. About half the participants in allele, about 22 patients out of 43, had what we call an objective response, which was either a complete response or a partial response. And half of that complete response or half of that objective response group was solid organ transplant. The other half that responded were stem cell transplant. 28% had a complete response. And you can see here that relatively in the proportions of the groups, the stem cell transplant group, about half had complete response and only about 20% in the solid organ transplant group. The median time to response was 1 month, which corresponds roughly to 1 cycle. The response duration, so if they did respond, and this is only in patients who responded, the median duration of response was 23 months. And 12 out of the 22 participants had a response greater than 6 months. Again, these are only in the responders. We're not talking about the response in the duration in non-responders. 7 participants were not evaluable. Three died, 1 withdrew, and 2 were newly enrolled, and 1 there were no specified reasons given for their non-evaluation. Next slide, please. Next. So here in allele, we have an overall median survival in responders of 18.4 months. And you can see the breakdown by type of transplant. And you'll see in a moment when I show you the graphics that everyone in the stem cell transplant group who responded survived. And then the median survival, overall survival in the solid organ transplant was 16.4 months. Again, in people who responded. You compare that to the natural history. So if people did not get treated at all, the overall median survival is 3.3 months. In the stem cell transplant group, they had a median overall survival of 0.7 months, so about 3 weeks. And in the solid organ transplant group, that natural history without treatment survival was 4.1 months. Next slide, please. So as I said, there's here the survival curves. So this is by response status. Overall, you can see that the overall 1-year survival was almost 85% in the responders, but it was only 35% in the non-responders for a hazard ratio of 0.2 in terms of overall survival in the responders compared with the non-responders. Next slide, please. If we break that down by stem cell, this is the stem cell transplant group, and as I alluded to earlier, the 1-year overall survival in the responder group was 100%. In the non-responder group, it was just under 36%. And because everyone survived in the responder group, there's no hazard ratio that can be estimated. Next slide, please. In the solid organ transplant group, the 1-year overall survival was about 75% in the responder group and about 33% in the non-responder group. So again, you have a substantial benefit in terms of the hazard ratio for survival being 0.28 for the solid organ transplant group. Next slide, please. So in terms of adverse events of special interest here, our most common adverse events from tab-cel treatment were disease progression, fever, diarrhea, fatigue, and nausea. And those were fairly well-tolerated adverse events. One of the more severe adverse events of special interest was graft versus host disease, because that can be a very severe complication. In the ALLELE trial, there was one case of acute graft versus host disease that occurred in a stem cell transplant participant. This was judged to be non-serious and unrelated to tab-cel, as people with stem cell transplant can develop graft versus host disease for other reasons. In the expanded access and the phase 2 trials, there were 5 other events of acute graft versus host disease that were reported. Again, most thought not to be related to tab-cel. You can get some theoretical severe adverse events like cytokine release syndrome, tumor flare, or organ rejection. These were not observed either in the ALLELE trial or other tab-cel studies. Next slide, please. So some controversies and uncertainties in our evidence analysis. So this was a single arm trial, so we don't have any comparative trial evidence. Our comparison is to natural history. But the treatment effect was large and consistent in this in a propensity match study that we looked at that took a subset of ALLELE trial participants. In cancer, 5 years is often considered a milestone. And so we don't have long-term 5-year durability in people who responded to treatment. Yet the median follow-up time was only 23 months at this trial. But we note that patients with relapsed or refractory disease die quickly, as I mentioned earlier, on the order of weeks to month. Median survival of 18 months is substantial in comparison. There may be clinically important differences in subgroup treatment effects, stem cell transplant versus solid organ transplants, and between different solid organ transplants, but the numbers in the trial were too small to understand whether there are any substantial differences between the groups. The safety data appears reassuring in the trial. There were cases of graft versus host disease observed in the expanded access protocols, and so we need more information to understand whether these may be related to treatment with tab-cel and how severe they may be. Next slide, please. Benefits beyond health and special ethical priorities. I think we mentioned most of these previously. So there are limited treatment options and poor survival rates for people living with EBV positive PTLD. This off-the-shelf T-cell therapy could allow for quicker access to EBV positive PTLD treatment, and particularly outside of specialized academic medical centers. And the therapy can be delivered in any setting, which may improve access. Next slide, please. We appreciate the public comments we received on this report. And one of the main comments we received is that this is an area with high unmet need due to the high cost burden, the current lack of disease management options, and poor survival. Next slide. So in summary, relapse refractory EBV positive PTLD has a very poor prognosis without treatment. Treatment with tab-cel led to partial or complete remission observed in a substantial portion of patients, extended survival for those patients who did respond, and relatively few severe harms. Next slide, please. And what this led us is to our evidence rating. So in terms of evidence rating of tab-cel versus usual care, given the high mortality rate of relapsed refractory PTLD, the survival benefit of tab-cel in those who responded, and the fact that it seems well tolerated with few serious adverse events, we have a high certainty of substantial net health benefit, and so we gave tab-cel an A evidence rating. And so that wraps up the clinical evidence section. I'm happy to take questions.
Thank you, Dr. Lin, for that really clear presentation, and congratulations to you and the entire research team. Grace, I just wanted to, push back is too strong a word, but maybe probe a little bit around the A rating. So this is ICER's highest rating that you and your team have decided to give to a therapy that, as you've acknowledged, is not in a randomized trial. So this is a relatively small trial, and there's not a randomized comparison, as you've outlined. Do you think that, just in terms of us as a panel weighing that, would you say that because not treating it has a very clearly very bad outcome, that evidence is adequate to justify the rating, which is to say that a randomized comparison probably would not be either ethical or feasible, or a larger trial that was randomized would not be either ethical or feasible? We'd just love your thoughts.
Yeah, thank you, Jason, for that question. Yes, I think that you're right. That played a strong role in our thinking. These are patients who you saw the median survival untreated is on the order of 3 weeks. So you couldn't even feasibly do a randomized trial at that point. And there are also no standard treatment options. So when after you've done the rituximab plus the chemotherapy, if that fails, basically people are given essentially the kitchen sink. Let's try this chemotherapy. Let's try that. Let's look for a clinical trial. There isn't really anything else that's effective. So when you look at that scenario where people are dying fairly quickly, there are no other treatment options, and you have a treatment now, it didn't work for everybody. It clearly didn't work for everybody, but for the people who did respond, they had clear survival benefit. That's what led us, even in absence of a randomized trial data, that led us to the A rating.
Thank you. That's very helpful to understand. I appreciate the explanation. I'll defer to my colleagues now. Don, do you want to go ahead?
Thank you. This might be the classic non-expert question, and it goes to the base. It's a basic question about PTLD. As I understand it, because it says this on slide 17, the incidence of PTLD varies by transplant type, and it can be as high as 30% for some kinds of solid organ transplant. It's associated with transplants requiring higher levels of immunosuppression. Can you rattle off some examples of solid organ transplants that fall into that category where there's up to a 30% incidence of this disease?
Yes, so thank you for that question. Yes, so we're talking about things like multi-organ transplants. So, if you transplant several organs, you have to have a high level of immunosuppression. Heart transplants require a higher level of immunosuppression. Lung transplants require a higher level of immunosuppression. So when you look across the types of transplants, those were, you need to be on heavier doses of immunosuppression. What that does is then your native T cells aren't able to respond to the EBV infection, and leads to the potential development of PTLD.
Thank you so much. Dr. Wadera Rishi, do you want to go ahead?
Yeah, thanks so much for that really excellent presentation, Dr. Lin. Whenever I see really early divergence of survival curves, like you showed in the intervention arm versus the comparison arm, building off of Jason's point that this wasn't a true randomized trial. I think we all understand the challenges of performing a randomized trial in a very sick population like this. But whenever I see early divergence of curves like that, it makes me think about treatment selection bias and or confounding. And so I just wanted to ask, how confident do you feel that your propensity score models accounted for all the differences that may have been present between patients who received the therapy versus sort of the usual care arm that I know it's not a randomized trial, but don't receive the therapy? How confident are you that you sort of have accounted for differences between those populations?
That's a great question. I think when you read, and this was an analysis done by from the allele trial. It wasn't our analysis, but they did account for most of the major risk factors for PTLD. I'm actually going to throw this question actually to our clinical experts who can, I think, speak as people who've treated patients with PTLD, may be able to speak to the propensity scoring and also whether, what the differences in between patients with PTLD and whether that might account for differences in response to tab cells. So Dr. Nikifor or Dr. Allen, if you would share your insights, that would be very helpful.
Yeah, apologies. I maybe should have directed my question there.
So this is Sarah. So I may go back a teeny bit and then get to that question, because that's actually I think, challenging question, not having been part of the sponsor group that ran and analyzed these trials. But let me just comment on randomized trials in cell therapy in general. And as some people in the audience may know, others may not, there's been an explosion in cellular therapy outside of the typical transplantation scenario in the last few years. And I'll comment on something that has come into the popular media, which are CAR, or chimeric antigen receptor T cells. And not that this means it's right, but mainly for reasons that we've discussed before in terms of having historical data of miserable clinical outcomes with standard care, which usually means not much available, versus a experimental therapy. This has led to CARs being approved. We now have, I think, 6 commercially approved CARs, all in single arm trials without comparison. So just noting that in the field, this is not an entirely new paradigm to follow. Also, this registration study had 43 patients, but this sort of pipeline, and I believe one of our patient advocates mentioned Rich O'Reilly at Sloan Kettering, these cells and cells like these have been under development for about 25 years. So we actually have, yes, it's not in this same trial setting, but we have experience with these same cells or cells like these, probably in over 500 patients, right? So I think that's part of what is coloring the view, at least of clinical experts such as myself, who've used these types of cells before. I can't really comment on propensity scoring, but I do agree that, as you were saying, each type of transplant has a different rate of PTLD. We do think that across these transplants, solid organ or HSCT, there is an incredible similar biology of what EBV does to these B cells to cause PTLD, right? So I think there's extreme heterogeneity of the patient population, but we do believe that what they're targeting is relatively homogeneous. But I think you have to take into account that these patients are coming in, some of them quite early after transplant, that's the majority of them, some of them quite late, right? Their immune systems may be in different states, and the immune suppression they're on is different. So I think that it's hard with the ends we have to parse out why in a particular patient group we may have seen different responses. So I wish I could answer that better, but I think it's a question of numbers. What I take away, again, it's my personal opinion looking at the data, is this still is a much better option than what is available elsewhere. And one of the things that Dr. Lin emphasized was the low toxicity profile of the tab-cel in the trials, which I think that clinical experts who've used these therapies outside of this trial would also attest to, help balance the risk-benefit ratio against some of your questions, which are very valid.
Thank you. That exchange and the questions are incredibly informative, and we really appreciate all of this. I guess I just want to say for the public group that Dr. Lin is putting in the chat that the survival curves from the allele study are not propensity matched. The propensity matching was done, but it is a separate analysis, just to be to clarify.
And thank you, Jason. And also, just sorry to interrupt. The other thing is that these survival curves are not versus natural history. The survival curves are responders compared with non-responders. And so we did not do an overlay of the natural history in the survival curves.
So it sounds like everyone in the Lancet survival curves are getting therapy. It's just that between those who responded and not.
That's correct. Thank you.
Thank you. These issues are so critical for our understanding, so we appreciate this really robust conversation. Don, I assume you still have your hand up from prior, is that right? Okay, thank you. Dr. Ross, Joe, do you want to go ahead?
Yeah, thanks, Jason, and thank you, Grace, Lynn, for excellent presentation. And I guess you sort of picked up the point that I was just about to ask about, and I think I'm sort of harmonizing around the same issues that Jason and Rishi were bringing up. I don't think there's any doubt about the efficacy of the therapy compared to the natural history of disease. And of course, I'm not here to paradigm challenge. You know, I understand what's happening in the cellular, like gene therapy space and the single arm trials and why they're being done that way. But I do definitely sort of disagree with giving it an evidence rating of A as opposed to a benefit rating of an A, right? Just in terms of the challenges, I would have very much liked to have seen the compared to the natural history of disease in terms of the curve. I do think Rishi's picking up on an important point in terms of selection bias. We also know that centers where therapies like this tend to be offered are the highest quality, most intensive, the sort of most wraparound care. So there's other benefits to getting treatment within a single arm study compared to the general patient population with this disease. So it's not, I don't doubt the sort of drawing of the conclusions around the benefit. It's more about sort of, and maybe this is just a bigger, more to the general issues of ICER and ratings, where we would place a kind of a short, small population sample study like this. So I don't know. I guess I can go and look around in terms of the natural history, or maybe one of our clinical experts can speak to it in terms of the speed with which people deteriorate and the survival challenges. I understand that the mortality rate is pretty high. It's just, so maybe that's a little bit of a soapbox than a question, but thank you.
No, Joe, thank you. Thanks for the thoughtful question. I mean, this is getting at exactly the issues we should be grappling with today. And I think just based on the nature of your comments, we probably should hear from both the ICER team about the rating and also the clinical experts about Joe's question.
Yeah, so maybe Dr. Allen, I think, had a comment on.
Yeah, sure. I can comment about the about clinical impact. So as you know, the transplant patient groups are quite heterogeneous, and as was mentioned, we have different rates of PTLD in different patient groups based on the degree of immunosuppression. So, for example, small bowel, pancreas transplants, heart, lungs versus kidneys. In addition to that, the potential impact, so I'm just going to focus on potential clinical impact and potential benefit. The potential clinical impact is likely to be more profound in the groups of patients where PTLD occurs more frequently, which also happens to be the groups where PTLD is likely to have a more devastating outcome. So, for example, a small bowel transplant patient gets PTLD more frequently than a kidney patient, and would also likely have a more devastating outcome from PTLD than a kidney patient, and might be that group that might be more likely to experience benefit compared with a kidney transplant patient. So there's definitely a differential impact based on the heterogeneity of the patient population, but the benefit is likely to be most profound among the patients who are more likely to get PTLD and are more likely to have poor outcomes from PTLD.
Thank you, Dr. Allen. That's helpful. And just given that the comment also had to do with the rating, I probably should just give a moment for the ICER team to either talk about, I know you've discussed this in the past, but also to specifically address Dr. Ross's comments, if you wish.
Yeah, I was going to give a quick comment, and Grace can add on to that related to the evidence rating. I think Dr. Ross' point is well taken, and we had a big debate about this as we were working through this. But I think at the end of the day, some of the things we considered, the ICER evidence rating is really helping us to answer the question of the net health benefit. That's one we take into consideration, and what's the level of certainty that we have as we consider the evidence. Now, the comparative study to the natural history that we're looking at, we had concern about some selection bias. This is a single arm trial. But at the end of the day, if we look at what we know that we see when we're looking at the natural history and what is happening in this trial is that all the patients that respond actually survive. And so it's an obvious answer as we think about the net health benefit, that there is a substantial benefit in terms of it's either dying or not dying. And there is a substantial benefit. There's also, when we think about the toxicity for patients that don't take this, like Grace had mentioned earlier, the kitchen sink is basically being thrown at those patients. A lot of the chemotherapy comes with a lot of toxicity. This therapy has relatively little side effects, as from what we can see in the clinical trials and experience from the expanded access programs. I think the other thing to think about is how certain are we, right? At the end of the day, we may not know how large, because of the selection bias, how large as we compare to the natural history, what that hazard ratio looks like. But we are certain in that net health benefit that the patients that respond to this actually survive. And that's why we ended up with that evidence rating. Again, I just want us to keep that in mind. The evidence rating, the question we're answering here is the net health benefit as we compare to not doing anything for those patients. Thank you.
Thank you, Fulso. And I'll just reiterate, it's so helpful for you guys to articulate as you are the internal deliberations that you had, because it helps us in our public deliberations. So thank you, Fulso. Dr. Nicolau, I think you have a comment.
Yes, thank you. So one is I wanted to second what was just mentioned in terms of some of the toxicities of chemotherapy, right? And I do think that the risk-benefit profile is something that plays into the perceived clinical impact here. But I also wanted to mention something in addition to non-randomized trials in cell therapy. One other thing that the field has done for decades, which has been federally mandated for allogeneic stem cell transplant, and I believe has been mandated after some of the chimeric antigen receptor approvals. And what academic centers do standardly is feed data into the Center for International Blood and Marrow Transplant. And this is a registry in which if the sponsors contract the manufacturers, they can look at the data. Sites can look at their own data, but payers also see the data. So there is a platform for post-marketing data collection that has been established and ingrained in the academic cellular therapy field. And a lot of our discoveries in transplant, and there have been many recent post-marketing real-world data studies in CARs, which have involved between 1,500 and 5,000 CAR patients, as opposed to the 100 or so on the registration studies, right? So obviously this is a rarer disease than some of the lymphomas and myelomas that get those other cell therapies. But even though I'm not discounting the evidence rating versus clinical impact question, I do think there is an opportunity and expectation in the cell therapy field that we continue to monitor and learn about these therapies as we go forward. And we have a mechanism for accumulating that data and publishing it to folks.
Thank you so much for your comments. That's super helpful. We probably have 1 minute left. We are on schedule, thankfully, despite the robust conversation. Any last questions from a CEPAC member before we move to health economics? Okay, I'm not seeing any. So with that, now we shift focus from clinical evidence, comparative evidence to comparative health economics and sort of cost effectiveness. And with that, I'd like to introduce Dr. Woojung Lee, who is the Associate Director of Health Economics and Decision Modeling for ICER. Woojung, do you want to go ahead?
Thanks, Dr. Wasfi, for the introduction. My name is Woojung Lee, and I'm going to present the cost effectiveness analysis for Tab-cel for EBV positive PTLD on behalf of the modeling team. Next slide, please. The modelers for this review include me and Marina Richardson, who is an Associate Director of HTA Methods and Health Economics at ICER. And Marina and I have no conflicts to disclose. Next slide. In this analysis, we aim to evaluate the lifetime cost effectiveness of Tab-cel compared to usual care in people with relapsed or refractory PTLD. Next slide. Before we discuss the specifics of the model, we would like to highlight the unmet need for this disease, relapsed or refractory PTLD, using two metrics, absolute and proportional AVLY shortfalls. These two measures illustrate the difference in the number of healthy life years that patients with the disease are expected to live under current care or current standard of care compared to the general population of the same age and sex. So you can see that the absolute shortfall for EBV positive PTLD is 26.4 years, which indicates that the average number of healthy life years that patients with this disease would have with the usual care is 26.4 years lower than those that they would have without the condition. And based on the proportional shortfall, the number of healthy life years for a patient with the disease are 89% lower than those that they would have without the condition. To give you a little bit more sense about how these shortfalls are compared to other diseases, we here present two examples. As you can see, the shortfalls for our condition, PTLD, of interest are much higher than those for a chronic condition with low mortality, such as osteoporosis. And also you can see at the bottom of this table that shortfalls for PTLD are closer to conditions like multiple myeloma, which is a rare cancer with relatively short life expectancy and relatively limited treatment options. So these comparisons suggest that there is relatively a significant unmet need in relapsed or refractory PTLD, despite the currently available treatments. Next slide. Okay, now I'm going to talk about the model. Method overview. To assess the cost effectiveness of Tab-cel, we developed a cohort-based Markov model from a healthcare perspective in the United States. And then the model followed a cohort of patients throughout their lifetime. Next slide, please. In terms of the model population, evidence suggested potential differences between patients who develop PTLD following solid organ transplant and stem cell transplant, particularly in terms of their underlying risk of death, potential treatment efficacy, types of usual care, etc. So to account for these differences as much as possible in the model, we model these two populations separately and weighted the results according to the proportions of patients who received solid organ transplant and stem cell transplant in the earlier trial. And based on the trial, the mean age of the overall population was around 49 years old, with female patients accounting for 44%. Next slide, please. We use a Markov model that consists of two health states, alive and dead. And within the alive health state, response status was tracked over time. And patients were classified as responders and non-responders after 1 month from the treatment initiation, which was based on the median time to response observed in the earlier study. And subsequently, a proportion of patients lost their response and can transition to the non-responder state, which was also based on the data in the earlier study. Next slide, please. There are several assumptions that we made in the model, and we wanted to highlight 5 of them. First, response was defined as complete or partial response. And this was because data on more granular classifications about response were not available for the usual care arm. And second, we assumed that patients surviving 5 years from the treatment initiation would have the same mortality and same quality of life as those of a post-trans population. And we also assumed that they would incur healthcare costs that are similar to the US population, general population. And this was because there is a lack of long-term clinical data, and 5-year survival is a common milestone indicating a favorable result, favorable disease prognosis in oncology. So patients who reach this milestone can be expected to be in better health. And another assumption was that the overall survival benefit of Tab-cel compared to usual care is the same for patients who underwent solid organ transplant and stem cell transplant. This assumption was made because there was a lack of data on the adjusted survival benefit of Tab-cel compared to usual care for these 2 populations separately. Assumption about utility values. The utility values were derived from a study in diffuse large B-cell lymphoma because there was no data specific to EBV positive PTLD. And this decision is based on an assumption that diffuse large B-cell lymphoma and PTLD share similar disease symptoms. And lastly, there is a significant variability in the chemotherapy regimens used as part of usual care in this patient population, which makes it very difficult to come up with the average cost of chemotherapy in our modeling. So we assume that the cost of CHOP regimen could serve as a proxy for chemotherapy costs in the competitor arm, because CHOP is one of the most commonly used regimens for this condition. And to account for the uncertainty, the cost of usual care were varied relatively widely compared to other parameters in a sensitivity analysis. Next slide, please. Now I'm going to talk about key model inputs. So first, overall survival for the competitor arm, usual care. We derived curves from natural history studies that are already introduced by Dr. Grace Lin in the earlier presentation. And this slide is showing a Kaplan-Meier curve plot for the solid organ transplant population, which was obtained from Darnita Cut 2021. This was a multinational retrospective chart review study of relapsed or refractory PTLD patients following solid organ transplant. Next slide, please. For the stem cell transplant population, we used SALC 2024, which was another multinational retrospective chart review study in patients with relapsed refractory PTLD following stem cell transplant. And these 2 survival curves that I just showed you were extrapolated beyond the survival follow-up period by fitting parametric survival models with several distributional forms. Next slide, please. Overall survival for Tab-cel, our intervention of interest, was estimated by applying a hazard ratio of overall survival of Tab-cel compared to usual care. And since earlier trial was a single-arm study, the adjusted survival benefit compared to usual care was not available in the study. And therefore, we obtained a hazard ratio from Barlev 2024. And this was an observational comparative analysis among relapsed or refractory patients with PTLD. This study, unfortunately, did not provide a separate adjusted survival benefit of Tab-cel for each of the populations that we are modeling. So the same survival benefit was modeled for both of the populations. Next slide, please. As I mentioned, among those alive, we tracked response status over time. And response was first assessed 1 month after the treatment initiation, again, based on the earlier study. And the proportion of responders at month 1 among patients receiving Tab-cel was obtained from the trial separately for the solid organ and stem cell transplant populations. And response data for usual care was obtained based on the response data in SOCI 2024, supplemented by earlier trial, again, for each of the populations. Next slide. And after month 1, we vary the proportion of responders over time in 2 different ways. 1, by accounting for their differential mortality, and 2, by accounting for the potential for losing response. In terms of the differential mortality between responders and non-responders, we used a hazard ratio of 0.2, which we saw in the earlier study already. And in terms of the probability of becoming a non-responder among responders, the monthly transition probability of losing response was calculated based on the 1 and 6 month response data observed in the earlier study. Next slide. Utility values. The utility values differed by response status to account for the potential differences in disease symptoms that patients are experiencing. And in addition to that, this utility associated with the adverse events of usual care was applied to differentiate the quality of life impact between Tab-cel and usual care. Next slide. Drug utilization. So the average number of 35-day treatment cycles of Tab-cel was 2 and 3 in the solid organ and stem cell transplant populations, respectively, in the base case, based on the earlier study. Next slide, please. In the usual care arm, patients receive rituximab with or without chemotherapy, and the composition of usual care was informed by the natural history studies that I introduced earlier for each of the populations. Next slide, please. Okay, drug cost. Tab-cel is still undergoing the FDA review, so a price for Tab-cel is not known yet for the US. So a placeholder price was obtained from IPD Analytics, which was approximately, and the treatment cost for a 35-day treatment cycle was approximately $287 and $500. And as mentioned, the cost of the usual care or competitor were approximated using the cost of rituximab with or without CHOP regimen. Next slide, please. I'm going to turn over the results. Base case results. In the overall populations, including both solid organ and stem cell transplant populations, Tab-cel resulted in better health outcomes, generating approximately 3.6 incremental quality adjusted life years, QALYs, compared to usual care, and 4.2 incremental EBLYs. However, it also incurred higher total costs, primarily driven by drug cost. Next slide, please. Using the placeholder price for Tab-cel, the incremental cost effectiveness ratio was above $150,000 per QALY or EBLY, which is the most commonly used willingness to pay threshold in the US. The cost per QALY was $184,000, which means that each additional year of healthy life gained from Tab-cel cost about $184,000. Based on EBLY, the cost per additional healthy life year was around $157,000. Next slide, please. Okay, now I'm going to show you the results from sensitivity and the scenario analysis where we explored the uncertainty around the base case results that I just shared with you. In one-way sensitivity analysis, where we varied one parameter at a time, we found that the adjusted overall survival benefit of Tab-cel versus usual care in the solid organ transplant population had the most significant impact on the cost per QALY. As you can see, a lower survival benefit resulted in an ICER that exceeds $300,000, while a higher survival benefit led to an ICER that's below $150,000. Another parameter that significantly impacted the ICER was the average number of 35-day treatment cycles for Tab-cel in the solid organ transplant population, which we varied between 1 and 3 based on the interquartile range observed in the earlier trial. Next slide, please. In probabilistic sensitivity analysis, where we varied all of the model parameters simultaneously within their respective uncertainty ranges, we saw that at a willingness to pay threshold of $150,000 per quality, the probability of Tab-cel to be cost effective is about 30% and 51% based on quality and AVLY respectively. Next slide, please. We also explore several scenarios, and we would like to highlight 2 of them. First, we conducted a modified societal perspective that includes domains beyond the healthcare system. And due to a lack of direct data on societal domains in this specific disease area, we used an indirect approach to value societal impact of the treatment. And we would like to note that this indirect treatment relies on a published relationship between patients' utility scores or quality of life scores and time use. And this relationship has not been specifically validated for patients with EBV positive PTLD. So there is an uncertainty around the estimates around the social domains. And also we can only measure certain domains, including patient productivity, either in labor or non-labor market contributions, time spent seeking care, consumption costs, and caregiver productivity. Unfortunately, we weren't able to estimate caregiver quality of life with this approach. Also, we ran another scenario analysis to explore the uncertainty around the long-term survival with usual care. And specifically, we observed that the survival curves for usual care flattened at a certain point in time, meaning that there is a significant proportion of patients remaining alive for a long time with usual care. And because there could be potential uncertainty in terms of the long-term survival due to very small sample size at later time points, we used a curve with lesser flattening in the scenario analysis. Next slide, please. And here are the results from the scenario analysis that I just talked about, again, using a placeholder price for Tab-cel. When societal domains were considered, the cost per quality or EVLY gained significantly decreased. And this was primarily due to increased productivity in labor or non-labor market during the extended survival period due to the use of Tab-cel. And with an alternative assumption regarding long-term survival with usual care, less flattening of the usual care survival curve, the cost effectiveness ratio increased slightly as fewer patients with usual care survived long-term and benefited from Tab-cel. Next slide, please. Using this model, we estimated health benefit price benchmark, and we found that the price range that would achieve incremental cost effectiveness ratio between $100,000 to and $150,000 per quality or EVLY was around $144,000 to $274,000 per 35-day treatment cycle. Next slide, please. Our analysis has several limitations, and we wanted to highlight 3 of them here. First, we could not fully account for the heterogeneity in disease progression and disease responses in this disease population. Although we model patients with EBV positive PTLDs following solid organ and stem cell transplant separately, current clinical and economic data were not sufficient to stratify the variability fully. Therefore, there is considerable uncertainty in the results for individual populations. And second, because the earlier study was a single-arm trial, adjusted clinical benefit for Tab-cel was not available in the trial. So instead, the adjusted survival benefit for Tab-cel was derived from an observational study, which may be subject to confounding bias, and also unadjusted response rates were used in the modeling. And finally, usual care for EBV positive PTLD in this population is not standardized. And so we assume that the cost of usual care can be approximated by based on rituximab with or without chemotherapy or CHOP regimen. but we recognize that some patients may receive different regimens, and that could result in significantly varying costs. Next slide, please. We received several comments from the public, and we would like to highlight one of them, which requested the inclusion of cost and quality of life impact of graft versus host disease in the usual care arm. We had several discussions with various clinical experts and reviewed available data, and we concluded that graft versus host disease is not a relevant consideration in this model. Specifically, clinical experts indicated that no causal relationship is expected between graft versus host disease and chemotherapy use, and rather it is more associated with the reduction of immunosuppression. And in addition to that, there is no controlled study examining the adjusted incidence rates of graft versus host disease between patients receiving TEPSA and usual care, and using an unadjusted estimates may introduce confounding bias. Next slide, please. Okay, in conclusion, TEPSA is expected to provide significant health benefits, but with higher cost. And at a placeholder price for TEPSA, the cost per QALY and EVLY are above the commonly accepted willingness to pay threshold, but we wanted to highlight that cost effectiveness ratio is largely dependent on the expected survival benefit of TEPSA and also the actual drug price of TEPSA. And thank you. I'll wrap up my presentation here and take questions. Thank you.
Thank you, Dr. Lee, and congrats to you and the entire economics team. Thank you for all the work and the rigor. We know this takes months to do. I just wanted to begin by saying that there are some questions in the chat box that I just wanted to read out. Dr. Sullivan, Brian on our panels has a question about the placeholder price. So obviously this is not a real price. This is just an estimate price. And maybe can I defer to Dr. Richardson, Marina Richardson, to comment on that for ICER?
Yes, for sure. So the placeholder price was based on analyst estimates from IPD Analytics, which is a common source that we use at ICER if we don't have a price available. So we won't know until the new year what the actual price would be. So the only other benchmark that we actually have is from a German HTA publication, which suggests a cost of 89,000 approximately euros times 3 administrations.
Thank you. That's very helpful. And I just want to bring out one more question to make sure it's in the public domain before I get to the people whose hands are up. George, do you want to ask your question about shortfalls?
Thank you, Jason. Yes, sure. It was more so clarification, if I may, with regards to, and of course it doesn't affect the model itself, but could I just confirm that the shortfalls that were noted on that first slide were compared to the general population? That's what I heard. And the reason for that question is I would have loved to see, if it is to the general population, I would have loved to see a comparison to patients who had undergone stem cell transplantation or solid organ transplant without developing EBV positive PTLD.
Yes, thanks for the question. You are correct that it is compared to the healthy life expectancy expected among the US general population. We unfortunately do not have the estimates compared to a post-transplant population, but yeah, I agree that it would be a useful information to see. Thanks for your suggestion and question.
Okay, and thank you. And thank you for your patience with people's hands. I just wanted to make sure all questions are in the public domain. Don, do you want to go ahead? Looks like your hands are up.
Yes, thank you. First, I want to say I apologize. In my zest to ask my previous question, I forgot to thank Dr. Lin and her medical evidence team. And so I thank them. And now I thank Dr. Lee and her team for the excellent analysis they've done. As a representative of the world of patients and families, where my mind goes as I listen to all of this is I imagine myself being the loved one or the patient being told by his care team, you know, you need a heart transplant or you need a heart-lung transplant if you want to survive. And it seems to me that my care team would have to tell me that PTLD is a significant risk for somebody in my medical situation, a very significant risk. And it would help, it would inform my decision about whether to go forward with a procedure like that. And it would be, I think, a real comfort to know that a treatment like Tab-cel is available in the highly possible event that I become a PTLD patient. And it seems to me that there's real value in that, in that comfort that is available to patients who have to undergo these significant transplants, even if they never become PTLD positive. And so my question for Dr. Lee is, does any of the analysis capture that value? And if it doesn't, should it?
Thanks. You're making a very good point. That's under discussion among a lot of researchers. So I think some researchers have suggested a value floor, which you may or may not heard of. It is showing all these value elements, including the one that you just suggested, that modelers can potentially include in their societal perspective. And I think what you're talking about maybe aligns with value of hope. Patients are hopeful for the potential treatments that they are getting. And then we can, there is no standardized way of quantifying value of hope, but I can imagine that, it could maybe be reflected in quality of life of caregivers and patients, during their disease course, meaning that, if they know that there is a treatment, that they know that if there is a treatment available for their disease, their quality of life will be better. But unfortunately, in our model, we didn't include that because there is no evidence in this specific population. And like I said, there is no standardized quantitative way of including it for now. But you're making a really great point. Thank you for that.
And John, if
Thank you.
let me just, I want to double click on Dr. Lee's really fantastic explanation of that. It's one of the things that we consider so critical of having you as an independent appraisal committee here as part of the deliberation, thinking about these other dimensions of value. So it was a perfect thing to bring up as you think about where we fall, even in the cost effectiveness range, because of these other things that are difficult to quantify, but that are very important. So thank you, John.
Thank you.
Thank you, Sarah. And Steve, I see you have a hand up. I'll just ask you to hold one moment. I'll get to you in a second. I just think the clinical experts have something that they want to say, if I'm understanding correctly.
Thank you. So I'm not a statistician, right? So it is so much easier to raise some of the limitations, but I did want to point out something. So in the registration study, people either had to have failed Rituxan or Rituxan plus chemotherapy. And the decision as to whether to start a chemotherapy regimen like CHOP was left to the provider's decision and would mainly be based on the organ transplant recipient's overall clinical status, organ function like kidney and liver, and blood counts, right? So that I just want to caution, as we're, and Dr. Lee, you didn't have a comparison otherwise, right? But when we look at those results, and we don't know the label at this point in time, but the way it was used on the trial was for patients who either could not get the standards that you evaluated or had gotten them and failed them, right? So I think that the question for your analysis is, in clinical practice, will we use it instead? But that's not how the trial was designed. The trial was designed for after, or those aren't available, right? So I just wanted to remind people of that context. In terms of the cost effectiveness, it really wasn't against, unfortunately, what you analyzed.
Thank you. Dr. Allen, did you have something to add?
Yeah, thank you. Thank you so much, Dr. Lee. Thank you. It's an amazing presentation. I have two questions. The first is related to what Dr. Kreis mentioned to some extent, and this relates to the extent to which you would build in the patient's health state preference values, so their utility values, and I wonder with the patients themselves. So I'll leave that with you. And the second question relates to extrapolations to the younger age group of folks below age 18.
And I wonder if there are any comments that you can make in that regard.
Sorry, Dr. Allen, do you want me to respond to your question, or do you want the patient
Sure,
to respond
sure.
the question to you?
Yeah, you can respond to those comments.
Yeah, so your first question was around utility values. We stratified by response status, as I mentioned in the presentation. The utility values were a lot higher for responders compared to non-responders, as you can imagine. But I want to highlight that there were no utility estimates for EBV positive PTLD, so we borrowed values from large B-cell lymphoma, because we assumed that these two diseases have similar symptoms, or this is the closest disease that we can find in the literature space. And I remember they use EQ5D to estimate the utility values. And then your second question about age, we didn't stratify our analysis based on age because what we heard from clinical experts and patients were that there is a significant heterogeneity among many different populations, but we focused on solid organ and stem cell population because that's where we see a substantial or the biggest heterogeneity in this population, and we didn't have specific data for younger patients. So I don't think I can say confidently how this analysis results will be generalized to younger patient population. So maybe I can toss it over to some clinical experts or patients if anyone can chime in. Thank you.
Does anyone have a comment either from the patient experts or clinical experts?
Well, yeah, from the point of view of pediatrics, I guess I can make two comments. Number one is the overall proportionate burden of PTLD is greater in kids, just proportionately, although they're more adults transplanted compared with children. That's the first point. The second is our assumptions around life years saved, for a child versus an adult, a 40-year-old versus a 5-year-old. And so I think that there's some differences there that that might be worth considering, where the years lost due to PTLD would be more profound in a 5-year-old than in a 50-year-old.
Thank you so much. I want to get to Steve. I know you've been incredibly patient. Actually, Dr. Kogut, why don't you go ahead?
Thanks so much. Just if it doesn't limit my ability to ask the question I had in mind, I just wanted to follow up with the point about the comparator and the use of chemotherapy. My supposition is that the cost of CHOP is inexpensive enough where it would be inconsequential to the model either way, and that's why we don't see it in the tornado diagram. Is that correct, Dr. Lee?
Yes, rituximab, although rituximab is a little bit more expensive than CHOP, overall the competitor costs are pretty low because the drugs that are used in CHOP regimen are all, biosimilars or generics.
I think Steve just froze.
Okay.
I'm not sure if you had a follow-up, but Felicia, I think your hand is up. Do you want to go ahead?
Yes. I was going to ask a follow-up comment and a follow-up question to what Dr. Nikiforou had said about the comparator. Again, I just want us to reflect on that a little bit more, because this trial was designed, the ALLELE trial was designed for patients with relapsed refractory EBV positive PTLD. When that happens, our understanding from clinical experts and some of the things we've talked about is there's really no standard of care after that. And so different things are really being thrown at those patients. And we used R-CHOP as one of those things that have been rethrown at patients, which is basically in that retrospective study where patients already had failed first line or they're refractory. Again, many of them, some of them still took rituximab again, some chemotherapy. It wasn't really specific, and which is really what we had modeled here. But it sounds like you would have suggested a different comparator in the model. I wonder if you could clarify that point more.
So if that question was addressed to me, there unfortunately is not a comparator, right? Because if you either have failed Rituxan, which is the anti-CD directed antibody therapy, or you don't have CD20 on your B cells, which is a small portion, but a portion of these patients, there's no benefit to using it again, right, in general. And I guess one of the questions could have been, if a given patient was not deemed a candidate for chemo, can you then say, oh, well, maybe we can use CHOP because you're farther from transplant, your liver is better, your kidney is better, right? So maybe you could wait and introduce something, but once you've given chemo and they failed it, you can't really give that again. And the other main therapy is to reduce immune suppression as much as possible, right? Because remember, even when we compare to other lymphoma patients, they at baseline have a much more normal immune system. We have deliberately devastated the patient's immune systems to allow them to retain the organ or the graft. But you have a limit, especially in the solid organ transplant, as to how much you can pull that back, or if a patient has GVHD. So I really don't think there is a comparator, which I think is why, if you look at the natural history for these patients who are relapsed refractory to those first 3 interventions, the overall survival is so short, right? And if you say, what could you pull out of the hat? There's nothing. That's why, as a provider and investigator on the tab-cel trials, I'm in Boston. We would get calls from Maine. We will get calls from Arizona. Where is the closest site that we can get some CTLs on an experimental basis? Because there really wasn't much else. I defer to Dr. Allen, but I don't know. I think we said I'm sorry, right? If we had exhausted those options. Dr. Allen, did you have a different approach, especially in kids who are more resilient than the adults that I treat, right? That's just a general rule. They have more options.
Yeah, no, I do agree with you, 100%. Yeah, nothing to add.
Thank you. I think that's very helpful context. I think for the purpose of the panel, I just wanted to emphasize that for the purpose of the comparison in the trial, we're basically using the estimates from this mix and match patients where doctors are basically doing what they can do. And so in terms of cost on the comparator side is where we had used R-CHOP. And so that may not be as definitive in terms of what that mix and match looks like. Just in interpreting the results, I just wanted to follow up on that comment.
No, thank you. That follow-up is super helpful. So I think we had a couple of technical issues. I think Steve's computer crashed and I think he's back on. I think he had a follow-up. So maybe I'll go to that first. And before I do that, can I just remind my colleagues from the CEPAC, just because this is a public forum and part of our process is public deliberation, if you have something to ask, please, I know in the Zoom generation, we put them in the chat, but please ask it publicly. I'm trying to bring stuff out, but just as a reminder. Steve, do you want to go ahead and follow up first?
Thanks. Sorry for my tech crash. I had a question just generally on the interpretation of the pharmacoeconomic results. Is that a non sequitur? I was away for the last 3 minutes, or should I ask that question?
I think it's not a non sequitur. Go ahead.
All right, great. Well, one of ICER's principles, of course, is to reward innovation. And when I reviewed this medication, it seemed like, gee, there's pretty compelling benefit in QALYs gained. There's an A evidence rating, and yet the language in the interpretation is that these results should be interpreted as maybe being optimistic, I think is the word that's used in the report. And so, you know, if you look at the PSA scatter plot, it's pretty tight and evenly dispersed. There's, you know, some scenarios where the cost per quality are, you know, within a range that would indicate good value for money. And so, you know, maybe just wanted to get some thoughts from the modelers and maybe anyone else that helped in interpreting the results that were derived with regard to the balance there. And maybe, you know, I know we didn't vote on cost effectiveness because we don't have a price, but you know, this information still goes out into the healthcare system and people are interpreting and making decisions based upon the economic modeling results. And I just thought maybe it could have been a little bit more balanced with regard to, you know, the benefits and the fact that it's, you know, we've looked at drugs that are $500,000 per quality, for example. This isn't that. So let me just leave it there and see if there's any comments from the modelers.
Well, thanks for the comment. Yes, we always try to be cautious about interpreting our results because there's a lot of uncertainty in our parameters that we use for the model. First of all, although we presented the incremental cost effects ratio, which was above 150K, I agree that it was close to the willingness to pay threshold, upper limit of the willingness to pay threshold, but it's based on the placeholder price. And it's also based on the assumed treatment cycles. You know, that's based on the earlier study. So in the reality, we don't really know how much actually patients are gonna spend for the treatment. So that's one big uncertainty that we need to deal with and we need to think about when interpreting the results. And also clinical benefit, it looks like there would be certain clinical benefit, but as I mentioned in the presentation, that survival benefit was not adjusted, and we are all kind of worried about, you know, this trial being a single arm trial. So that means that there is a wide uncertainty or big uncertainty around the survival benefit, which was actually a main driver in our analysis. So that was the reason why we were a little bit hesitant to say that, okay, we are confident that this will be cost effective, because there are parameters that with high uncertainty. I hope that's helpful.
It is helpful. We are a minute or two over time. We only have one public commenter, Dr. Cavalli, who I can see has joined. But I just want to take, since we only have one public commenter, I just want to take a moment more to make sure I've exported all the questions, these very good questions, but I want them in the public domain. I think Don had a question for the patient experts. And so, Don, I'd invite you to close with that before we move to public comment.
Sure. Well, sort of following up on what I was talking about before, I wanted to give the patient experts an opportunity to take their minds back to the juncture where they were deciding whether they obviously decided yes, but they had to make a decision to move forward with a significant organ transplant. And I'm wondering and it was a long time ago, and so the state of medicine has changed, but I'm wondering if they could comment on what it felt like to face that juncture in their own health odyssey and whether it would be a source of comfort and value to them to know that a drug like this was available without the foreknowledge that they would in fact eventually be diagnosed with PTLD.
I'm happy to start. I guess it wasn't known at the time that it was an option until Dr. Juliet Barker was my kind of transplant doctor, and then she contacted Richard O'Reilly, who I guess had only done it a few times. I'm not sure what patient I was in the initial. That was 2008, but it would have been great to know that that was there, and hope is certainly an interesting value. I guess the thing that has been coming up to me is around toxicity. I think that's a really, really part that like really hit me. And that's where, having done ICE and CHOP and lead up to a bone marrow transplant, and then, you know, the the months of like trying to get my immune system to grow, and then, then to have rituximab thrown at it, having the PTLD, the rituximab, like all of those were way more like hard to endure and toxic in my just personal experience with my doctor, but like I could just feel them like kind of like just the side effects were so intense. And then the when Richard O'Reilly came in with a third party sort of T cells, it was like there was no side effects. It was like, I was given a week or two to live, but here's this procedure that isn't toxic and it's killing this lymphoma. So anyway, that was the main piece, was just, I think for me, is the highlight of how the lack of toxicity was remarkable in my experience. And that was one thing I think that's been mentioned that needed to be highlighted more.
Thank you so much. And again, contributing your perspective is so helpful. We're a few minutes over, but it just really is so helpful to the discussion and the deliberation. So thank you for joining us, and thank you for adding that. So with that, I am going to transition now. This is the last thing before lunch, to public comment. We have one pre-registered public commenter